So today I will talk about endoscopic lumbar interbody fusions. This is a case of 53-year-old female patient who was suffering from chronic low back pain and left side dominant radiating pain that has not responded to conservative treatment. An X-ray and MRI shows degenerative spondylolisthesis and stenosis at the L4-5 level. As preoperative planning in the axial view, I draw a line from anterior disc to the lateral facet for the trajectory. For this patient, the skin entry point is measured 7 centimeters from the midline. The patient was placed in a prone position with hip and knee joint flexion under the general anesthesia. At the AP and lateral fluoroscopic view, a line is drawn parallel to the lower end plate. And the point of 7 centimeters on this line is marked. After making an incision in the skin, a spinal needle is introduced into the disc space. At first, it has to touch the lateral facet joint and then slip into the foramen, then lands onto the posterior annulus. I do epidurography at this point to see the shadow of traversing an external nerve root. Then I insert the needle deeper into the disc space, followed by discography with indigo carmine. It stains the degenerative nucleus. A K-wire is inserted through the needle, and the needle is withdrawn. A serial hand drill are useful to expand the neural foramen.
So you're in Cambin's triangle right there, correct?
Yes, of course, yes. The foraminoplasty is important to introduce a larger working channel. So it is also useful to perform annulotomy at this stage by pushing the hand drill into the disc space. Next, an obturator is inserted. After serial dilation, I put a working channel that is safely placed on the Cambin's triangle.
What system are you using here?
I'm using a Joymax tensile system. I use a 60 millimeter working tube with a long leaf for fusion, which is larger than that of transforaminal discectomy. You also have to confirm that your working tube is not compressing the external root on the AP view. You can see the tip of working channel is docking on the posterior annulus, while the left surface is facing the facet joint. And then endoscopy is introduced. Now with the working tube, I'm cleaning the soft tissue so that I can see the bony anatomy. So now you can see the tip of SAP. So you have to do further foraminotomy, which is important to create space for the cage insertion. a high-speed drill is used to dissect the base of SAP. Now my RF tip is probing into the lateral recess.
Is the patient asleep?
I'm sorry?
Is the patient asleep?
Yes, it's under conscious sedation. The endoscopic calcium is useful to remove the bony fragments. There are some residual part of facet joint as well. So I need another drill to resect it. So after removal of this residual facet, you can see the disc space. So here is the Campbell's triangle. So this discectomy starts at this point because I have already done annulotomy with my hand drill at the beginning. So you can see the blue stained nucleus directly. The first step is the internal debugging. So I am using endoscopic forceps to remove blue color nucleus until I can see the yellow cartilage endplate. This is a really time-consuming job. So I have seen a video that Dr. Chul Kim is using the power drill or some special instrument to do this nucleotomy, but I don't have it. So I need just forceps and radio frequency to clean up the nucleus. So you have to be patient during this stage, but it is very important for the fusion.
So when you use a blue dye, is the assumption that the degenerative disc is blue and then the normal disc is not stained?
So usually it stains nucleus purposes. So the annulus and cartilage is not stained. So you can say the blue color is just nucleus.
Because it looks like you're also getting some nucleus that's just white without any of the staining.
Mm-hmm.
So it doesn't completely stain the nucleus, correct? It's not like complete staining.
No, it's not complete staining. You just differentiate these two things, and you can figure out which is the nucleus and which is the cartilaginous endplate. So now you can see I'm using the blunt dissector to use to detach the cartilage from the bony endplate. So this en-bloc detachment to the contralateral side is necessary for the effective removal of this cartilage. It is also removed with forceps as well. So the main reason of my staining the nucleus is to figure out what I'm doing and how much I resected the nucleus. Otherwise, you need a lot of fluoro during the surgery.
Mm. So you did a foraminotomy, but you did not necessarily do like a laminotomy or a lateral recess decompression, correct?
No. It depends in cases, but for this patient, I didn't need the direct decompression. but I've already dissected the superior facet. I think I've decompressed the foramen and some part of the lateral recess as well. So the radiofrequency and forceps are used to clean the loose tissue for meticulous preparation of the fusion bed. So now I'm almost finished my discectomy procedure.
So is that an RF probe that you're using there?
Yes.
That's a pretty good view of the disc space.
Mm-hmm.
So you use the RF probe to kind of just clean out some free fragments of disc?
Yes, I'm using RF probe or the Holmium laser. For this video, I couldn't use Holmium laser because other guys using that. When the appropriate side of cage has been measured with trials,
so the cage fits down the tube, same tube?
yes. I put allograft and biologics insert through the funnel into the disc space.
What's the diameter of that tube?
The tube is a 60 millimeter tube. I usually pack 15 cc of bone graft for one level fusions.
15?
15.
Do you use
15
anything else other than bone graft?
It's allograft bone graft, and sometimes I use BMP or I factor for the interbody.
Got it.
I like to use 3D printed titanium cage for interbody. The working tube is tightly guides the cage trajectory, preventing the neural injury. You can also use a protector if you like. So under the fluoroscopic view, you can see the location of cage in its final position. You can also confirm the position under endoscopic visualization as well.
Looks great.
Thank you. And post-operative X-ray shows a good cage location with Percus screw added. And the MRI shows good decompression of the foramen and the widened spinal canal. The patient's pain has been improved a lot after surgery. She was discharged from the hospital the next day.
So Dr. Pei, if the patient did have some central stenosis and some lateral recess stenosis, when would you do the decompression relative to the interbody fusion?
For my best indication for the endoscopic interbody fusion is spondylolisthesis, or some cases need indirect decompression. Otherwise, I need direct decompression with interlaminar approach for the central decompression, central unilateral or bilateral decompression as well.
I'd like to leave some time open for the faculty members as well. So maybe Chris, Chol, and Larry, if you guys have any questions. I mean, this is really fascinating because, in all honesty, I know Chol does a little bit of this, but Chris, I think you've done some as well. So I think this is probably at another level, right, with respect to doing endoscopic interbody fusions. This is probably the kind of the holy grail of doing outpatient fusions, from my perspective. I'm gonna leave it open for the faculty members to ask some questions for Dr. Bay.
Well, I've got a lot to say about it.
Let's hear it, Joel.
I just started doing the endoscopic fusions, and I'm surprised at how well the patients are doing. And it is one incremental improvement over an MIS TLIF. So I'm really excited about this whole strategy. There's lots of obstacles to overcome, including being able to do a good decompression, a good inner body reconstruction, and end plate preparation and bone grafting. But I'm amazed at how well patients are doing and how just a slight amount of indirect decompression in these settings provides significant amount of relief.
So let me ask you guys a question then. Are you guys believers, like in a grade 1 or grade 2 spondylolisthesis, are you also supplementing this with a central decompression if they do have central stenosis? Chol says no. How about you, Dr.
No, if I have to do a direct decompression, I do an MIS TLIF.
How about you, Dr. Bay?
It depends on cases. But in some case of degenerative spondy with central stenosis, in case of the lamina, the inferior lamina is pushing the spinal canal. So in that case, we just need indirect decompression of the for the spinal canal decompression. You don't need direct decompression. So in that case, I will do endoscopic fusion without direct decompression. Other good indication is ischemic spondylolisthesis, where you just need the restoration of the disc height and widen the neural alignment. That is good enough.
So there's a question regarding how do you ensure that you get a good end plate preparation by using an endoscopic approach?
Yeah, so I see with the endoscope, it's actually almost a little bit easier to do an endoscopic kind of fusion than like a discectomy where you have to really reach out and find that disc where it's pushing that nerve. Because here you're just going in the central part of the disc and just kind of destroying all that disc and cartilage end plate. And so, there's some other tools like sort of tulip expansile paddles that you can use to help with end plate preparation, and kind of backhoe sort of cannulas that you can do it. And you're also looking right at it. So you can see that you have eburnated bone. So that's kind of nice. And actually, I was part of a study where we kind of blinded ourselves, and that's going to be published pretty soon, doing endoscopic discectomy end plate preparation versus kind of MIS TLIF. And it showed equal or maybe even a little bit better preparation, which surprised me actually, because I think you can definitely do adequate end plate prep. I didn't think you could necessarily do better, but that's where the data was showing and was blinded. I've done a few of these endoscopic fusions, but for me, it's really nice, really slick, and it's actually, again, easier than the discectomies. But what's weird is that after, and he didn't show putting the screws, but after you do the discectomy in the inner body, then you take all that out and then you extend the incision a little bit and put the screws in. And so at that point, I can do like a big, then it's just like my MIS TLIF, same corridor. So I don't know that I've seen like a huge advantage. I think it's cool, and it's nice to be able to verify that you removed all of the disc tissue and prepared the end plate with the endoscope. But I end up, when I do them, still doing like that 1 to 1.5 inch incision to just put the pedicle screws in just to get to each pedicle, after I do the endoscopic discectomy. So then I've just tended to put the bigger non-endoscopic cages in.
Have you guys, so this is a thing. Let me ask you quite honestly, because Chol brought this up. He said he felt like the patients were like doing better relative to MIS surgery, which Chol, you were like a tube-based guy for many years. Now I can definitely see your practice sort of transitioning into endoscopic. Do you truly think that there's a difference? And I think for me it would be, are the patients going home the same day? Like, I think that is sort of the holy grail of fusion surgery, whether or not you can do these on an outpatient basis. So is that making a difference by doing it endoscopically?
I think so. I think not doing a full facetectomy and all that bony work and the destabilizing nature of that part of the procedure compared to a endoscopic interbody reconstruction makes a big difference. I think the bony work is where it matters. So I have several patients going home the same day with endoscopic TLIFs, but very rarely with MIS TLIFs. I think I can get them home with an MIS TLIF, but I'll have much better luck with my endo TLIFs.
So Dr. Bay, there's a question from the audience that's, has anybody tried transforaminal for disc preparation of the disc space under visualization under the endoscope, and then the MIS TLIF for a hybrid technique? So almost, I'm thinking maybe a biportal technique, whereby you're putting in a scope to visualize and do the discectomy, and then through another portal putting in the MIS TLIF. Have you tried that technique before, the UBE, or unilateral biportal endoscopic technique?
No, I didn't try UBE technique by myself. One of my colleagues, he's performing the UBE, so I've seen a lot of cases. So basically, it's the same idea, but a different thing is you can use the microscopic tools for your endoscopic fusion. So it's according to your background and your training and your experience. So I think both are very useful for the endoscopic fusion. But different thing is, like Charles said, it's about the bone work. So when I go through the transforaminal approach, even if it's not necessary, you don't need to do the full fascectomy and stabilize the bone. Just to increase the disc height and put the screw that's good enough. It's the same idea with the lateral interbody fusion and the percus screws. You don't need to do the fascectomy or decompression while you are doing the lateral interbody and the percus screws. So I think transforaminal interbody fusion is same idea with such a lateral interbody and the percus screw surgeries.
Chris, you brought up the fact, nice dog, by the way, very cute.
Yeah.
Good dog. You said that when you look at the post-op MRI, there's very little to no muscle damage. What do you mean by that? And how does that correspond to patient outcomes, Chris?
Oh, well, I was just commenting on Dr. Bay's postoperative MRI. I think at Woodrow, they get post-op MRI like almost immediately post-op. And, you can't even really see the tract where he went through, which was really nice. And I think, we've all seen the big open, post-open midline fusion MRIs with a lot of muscle devitalization and everything. And so it's just kind of showing how nice and it is to the muscles with the approach.
Thank you.
Yeah.
And I'm going to say something controversial, but I think that the pain, regardless of if it's MIS or open, a lot of it is in the instrumentation related to the pedicle screws. And I think it's because the pedicle screws, the entry point is right at the facet capsule. And believe it or not, it's very close to where our pain colleagues do a medial branch block, right? Which is a sensory nerve. And we're putting in a screw through this, through the capsule, which has nociceptive fibers, as well as the entry point where the medial branch lives. And I think that's where a lot of the pain is. So what are your thoughts on, as we sort of develop these expandable cage technologies of doing standalone cages without using pedicle screws? Larry? You're on mute, Larry.
One of the things is Dr. Bay really elegantly showed that, you can get a very good end plate prep. You can get a very nice size cage in. But I think we're all agreeing that if there's a lot of central or significant bony foraminal stenosis, we're relying on indirect decompression for these techniques. Like, for example, when we do lateral standalones, right? And the difficulty of not putting something to support the anterior column. And we've seen this I mean, we all were there when we did lateral standalone. We just put a lateral cage, and to Dr. Bay's point, don't do any bony work whatsoever. And they would do well for a while, but then there'd be subsidence, right? And subsidence, I think, is the enemy whenever we're doing indirect decompression. So our long-term outcomes were sometimes suboptimal in some patients, not all, but people with softer bones, smaller cages. And if we lose the indirect decompressive technique without doing aggressive bony decompression in bony stenotic patients, in other words, improperly selected patients, then I think we may have a problem. That's certainly what we saw with the lateral experience. And I think it'll probably play true to this as well. But I agree with you 100%, Jeff. Screws to the back are painful, and that's why we've all struggled with lateral standalones with plates, which help but don't still prevent subsidence. And so I think that that you have to judge each separate case to see if you need pedicle screws. But I think that's the great enemy, is subsidence, and also not putting in pedicle screws if possible, because I agree, we've taken a lot of MIS screws out over the years because they can be painful.
So this is a thing, like, I think as these technologies evolve, right, like it's that whole thing of before, when we did open surgery, when you had an ALIF or an open approach, you can see the nerves, you can see all the structures, and you try to put in a big, like, allograft, femoral ring allograft. Remember those things? And they worked really well. They were super stable. But then the problem is, as we went into MIS and went to smaller incisions, smaller tubes, then we went into smaller interbody static cages, right? So now as we start seeing these advent of these cages that can expand in multiple directions, I really do believe that it's the stability, what you just said, Larry. Like, we want stability. Like, we've all been in that situation where you have a massive disc herniation and you can see that it's unstable, and you're like, I wish I could just put in something there to stabilize this, right? So how would that be any different from us doing that exact same outpatient microdiscectomy with that massive disc herniation and putting in an expandable cage that's, like, super solid and that provides it innate stability? So I think that's going to be the next phase of our development. I really do, I don't know if is Dr. Braxton on the call. Can you talk about your ERIS protocol? Because this is something that I've seen before, and you're saying that through using ERIS, as well as this certain type of block, right, the erector spinal block, that you're able to send patients home the same day. Can you talk a little bit about that, Dr. Braxton? Can you unmute yourself?
Audio.
Can you hear us?
This does video. We can just read his lips.
Hey, you guys hear me?
Yeah, we can hear you. Tell us a little bit about your protocol here.
Okay, so this has really been a game changer for my practice, and the beauty of it is it doesn't really change the actual surgeon workflow at all. So prior to surgery, the anesthesiologist will place 2 catheters at usually T10 or sometimes T12. And infuse them with ropivacaine on either side. This gets in that inner transverse plane, and they go home with a box that's filled with ropivacaine that lasts about 3 days. They get 3 days of non-narcotic pain control when they leave, and I think that's the real game changer. We're just starting a registry for insurance companies to look at how this changes their amount of narcotic usage. And I just did an MIS TLIF on a 70-year-old lady yesterday. Now, she was a Vail 70-year-old, not a Pittsburgh 70-year-old. She went home. Her length of stay was 2 hours after an MIS TLIF with large, she had large synovial cysts, unstable spondy. I actually had some pictures from that case. I can show that, maybe share those a little bit later at another time. The thing that I do, which I don't know if it's going to make a big difference, I believe in it, is I do my surgeries awake. So I've kind of migrated from an epidural block to a spinal block for my TLIFs. And when they're awake, there's something I believe in, kind of preventative analgesia. If you're not sensitizing the CNS to pain during the surgery, I think they tend to have less pain after the surgery. So the recovery is much faster. One holdup for an ASC is postoperative nausea and vomiting. We've seen zero postoperative nausea and vomiting when they're awake with either a spinal or epidural block. To Dr. Rowe's point about the medial branch pain, this is something I learned from Mike Wang, is before I place my percutaneous pedicle screw, I localize it with a spinal needle, which is right where the medial branch is, the medial branch of the dorsal ramus, and I inject 10 cc's of ropivacaine. I was a big believer in liposomal Marcaine. I've migrated away from that and not found it necessary with the catheters. And I'm the only neurosurgeon in a large orthopedic group. I've learned that all my orthopedic colleagues are, when they're doing shoulders, knees, or hips, they're sending people home with these catheters. And I just wanted to figure out how could I do that for spine surgery. So this is nothing new to medicine. I didn't invent this by any means. My other colleagues were in orthopedic surgery have been doing this for years. And I just adopted it probably about 6 months ago. We had a little bit of a slowdown during COVID, but we've kind of come back up, and really happy with my awake T-lifts with their pain control afterwards.
But that erector spinae block, that requires certain training. From what I understand, it requires like ultrasound guidance as well, right?
Yes. The anesthesiologist used an ultrasound to place it. Obviously, at T10, if you're going to kind of do it on an anatomic technique, you could go into the pleura. So it's important to see the transverse process on the ultrasound. I have a few pictures that I could, maybe share at a later time of the anesthesiologist actually doing them. They're comfortable doing it. They've gotten away. They do this for rib fractures all the time, and for mastectomies. So they're already comfortable with the procedure. I was curious if blocking it at T10, where it's out of my field, would give adequate analgesia at L4-5, L5-S1, and it has. And I think there's a potential space right superficial to that intertransverse ligament where the medication can slide down. And I shared the protocol that they use. The patients also like it because it's as opposed to a pain ball, there's some demand dosing where they can actually give themselves an extra boost while they're at home. And then they take the catheters out when the medicine's empty. They go home with a box that's already mailed and addressed, and we recycle the whole system.
Well, maybe we'll think about maybe next year bringing in one of the anesthesiologists that actually do it to go over the technique. Because I've heard this from several of my colleagues that do awake spine surgery. They swear by this block.
Yeah.
So thank you for sharing that. Really appreciate it. Now,
Hey, Ernest,
go ahead.
what's the system that's used? What's the unit? It comes prepackaged?
Yeah, it's called a InfuBlock catheter. I'll text that to you later, but I can tell you the exact name. And I'll send it to you. I'll send it in the panelist comment, the name of the company that we use. It's different than the paintball because it's something that can give demand dosing. There's a lockout on it, obviously for safety. We don't want to get too much ropivacaine. And I still prescribe narcotics. I think there will probably be a time when I don't. I just give a week's supply. It's very rare, extremely rare, that I have to refill the narcotics on an MIST lift.
Yeah, if you wouldn't mind sharing that with either Linda, Ashley, or Alexis, and then they'll distribute it to the rest of the group, because I think that's going to be really important information. So thank you for sharing that. We're running a little bit behind, so we're going to try to catch up here. We're going to do one more poll. So can we put up the second poll, Alexis? So please select all of the types of surgeries. Oh, no, wasn't there another one? The number 2 on the endoscopic? There you go. So do you perform tubular MIS surgery, yes or no? Do you perform open surgery, yes or no? Oh, okay, forget about this one. I think this was supposed to be from the previous, but in any event, let's just answer it and see what it shows, to see what most of the people answer. So the question is, do you perform MIS tubular surgery, yes or no? And do you perform open surgery, yes or no? So do you perform tubular MIS surgery? 63% said yes, 37% said no. Do you perform open surgery? 84% still said yes, and 16% said no. So it looks like we have a pretty mixed crowd of folks who still do majority open surgery. And then of those MIS surgeons, they also supplement that with a lot of MIS tube-based surgery, and then probably less surgeons who do endoscopic surgery, but the majority of those surgeons want to do some sort of endoscopic surgery.